Now, you've been looking at preventing children who've been cured of cancer from dying either from reoccurrence of their cancer or from some completely different cause. Can you tell me what it is exactly you were trying to do in this massive study?
We can. So this is a study of 5-year survivors of childhood cancer. This is a study called the Childhood Cancer Survivor Study. So to even be eligible, these children had to be 5-year survivors of their primary disease. And from a clinical standpoint, as a clinician, when you walk into the room with a 5-year survivor, you celebrate, you throw the confetti, and in your mind you imagine they've beaten it, they're done, and they go on about their lives. But the truth is beyond that 5-year time point, 18% of 5-year survivors will be deceased by 30 years from diagnosis. That's 1 in 5. So there's still a battle beyond that 5-year time point.
What is it that goes wrong then in childhood cancer in the long term?
So for some survivors, they'll have late recurrence of their primary cancer, and that can often be fatal. But as time goes on, the real threat for mortality are the late effects of cancer. So children who had radiation or chemotherapy to beat their primary disease, but those results in late effects down the road, so a higher risk for breast cancer or brain tumors down the road due to radiation, or heart disease from anthracycline chemotherapy, things that you may not see till 15, 20 years down the road. But those risks are increasing with time and they lead to late mortality.
Now, there have been a number of different studies. You hear about more gentle regimens that have addressed this issue, haven't there? But you've pulled it all together. What specifically did you look at?
Right. So one of the brilliant things and one of the miracles of the story of curing childhood cancer is that now 83% of kids will beat their primary cancer. And as we've learned who it is that will beat their cancer, we've been able to back off of therapy for primary diseases in many cases. So for Wilms tumor, ALL, Hodgkin's lymphoma, we can back off of radiation and chemotherapy for low-risk patients. And so what that's resulted in is down the road, they're surviving to the 5-year time point just as well, but beyond that, they have lower risk for late effects. And what the study shows is lower risk for mortality due to late effects because we didn't treat them as heavily to begin with.
Okay, so what you know about is that techniques have been developing for having more gentle therapies.
Absolutely.
But what can you now say about what has in fact happened as a result of this?
So as a result of it, down the road, fewer deaths due to these late effects, fewer deaths due to secondary breast cancer, secondary brain tumors, and heart disease. That's resulted in the extending of the lifespan of survivors. So we can now say we've extended the lifespan of survivors. Those diagnosed in more modern treatment eras are living longer, living well past their 5-year time point to 25, 30, 40 years down the road.
Now that's all very reassuring as a general picture, but what are the numbers on this? What do you actually have to do to ensure that your patient has the best possible chance in the long term?
Right, so beyond the 5-year time point, first of all, we have clinical care guidelines for long-term survivors, and those guidelines recommend certain screenings and follow-up time periods. And what we'd like is for all survivors and their doctors to subscribe to those guidelines. Secondarily, it's our job as researchers to identify who are the high-risk populations for late effects down the road. And if we can identify who they are, then intervene on them to either prevent or reduce the rate of late effects.
And what's the sort of trade-off between chemotherapy and radiation and different regimens within chemotherapy?
Right. Well, first and foremost, we have to cure their primary disease. Okay, so if we still need to use combinations of both to do that, we have to do that. But if we can reduce them as much as possible, that lowers the risk for late effects. So the radiation and chemotherapy are not the bad guy. They're the good guy. They beat the primary cancer, but moderating them when needed is the best approach.
And how do you do that?
Yeah, so for example, that's come through clinical trials, frontline phase 3 clinical trials. So if you think through Hodgkin's lymphoma or Wilms tumor, where brave trialists now decades ago said, we can potentially reduce therapy, maintain excellent 5-year survival, and reduce late effects. And so those were brave trials, but they succeeded. They showed great 5-year survival. So for example, in Hodgkin's lymphoma, in the 1970s, survivors would receive up to 40 gray of chest radiotherapy. Now, currently, some survivors will receive none if they're early responders to the chemotherapy. So going from lowering dose to potentially even eliminating radiation when possible.
What potential impact do you think there might be in the future from the more targeted therapies that are coming down the line?
So that's a great question, and we don't know the answer in regards to long-term late effects because we don't have enough children with enough of those targeted therapies who are well beyond the 5-year time point. But with time, we hope that we can roll those type of patients into our childhood cancer survivor study cohort and follow them as well. But there's a mystery there. We don't know a lot of the late effects of these novel therapies.
So what are the basic clinical messages coming out of this all then?
I think the main clinical message is good news to everyone in the field. We've extended the lifespan of survivors of childhood cancer. So we're beating cancer, and now you're surviving it longer. But the next step is not just survive it longer, not just extend the lifespan. We need to extend the health span. So it's one thing to survive longer, but we need to make sure the health of those survivors is maximized and that the risks for toxicities are reduced. So extending the lifespan is one thing. Let's now improve the health span.
And the biggest outstanding difficulties might be what? Are they cancer or
they
other
are.
factors?
The number one threat to life of long-term survivors is second cancer. Not the first cancer coming back, but a second cancer due to the therapy they received. So as much as we can moderate that, the number two cause of mortality is heart disease, early heart disease. And we're talking when survivors are in their 30s and 40s, when they're still young, having their own children, mid-career people. So it's an important time of life.
So there are some clear messages for clinicians perhaps avoiding some of the cardiotoxic regimens and also getting regimens that are more effective for the
Sure,
cancer?
we need to be on the search for that, or for cardioprotectants, agents that may come along and while you're administrating the cardiotoxic chemotherapy, protect them through cardioprotectant agents. So there's all kinds of strategies, and we need to continue them. So far, though, the strategies that have been employed over the last 2 decades are showing good effects.
So here from ASCO, what's your brief message for clinicians that they should take home from this then?
Yeah. First of all, for our long-term survivors, don't forget about them. It's not as if beyond the 5-year time point they become just like everyone else in the general population. They're not. They're different. They're special. They need long-term follow-up. Secondly, there are a set of guidelines for long-term follow-up. The Children's Oncology Group has produced long-term guidelines for follow-up, and they're readily available on the Children's Oncology Group website. And so I'd strongly urge, if you have a long-term survivor of childhood cancer in your practice, follow those guidelines.